The video series Detection and Lifestyle Monitoring was developed by the Georgia and Oklahoma Academies of Family Physicians as part of the Go Diabetes Initiative. The Detection and Lifestyle Monitoring series consists of 5 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA-PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
The initial foot exam, and this is a lot of just words, it's not so much important to memorize or know, just to realize that with these G codes you can get higher levels of reimbursement over and above your normal ICD-9 codes and coding that you get for each visit. That with this diagnosis of LOPS, or loss of protective sensation, you have to go through the diagnosis, the patient history, physical examination, which includes, and this spills over to the next slide, visual inspection of the forefoot, hindfoot, and toe web spaces, evaluation of protective sensation, foot structure and biomechanics, basically just evaluating for a Charcot foot or similar, evaluation of vascular status, pulses, and skin integrity, and then any recommendation for specific footwear, plus patient education. That's something as simple as saying you should wear shoes at all times in your house, when you go outside, so on. It doesn't have to be anything in depth. I mean, you can cover this in less than 30 seconds. The reimbursement for that on Medicare is currently about $67 for the initial assessment. That's not bad. Now keep in mind, that's over and above your moderate complexity visit or whatever you want to do, okay? These are G codes. So then you go on, well, this next code, 0246, the follow-up evaluation of this. Basically the exact same thing, okay, in what you incorporate. But the point is, especially in academic medicine, where if your residents, your supervisors are really harping on you to look at the feet, get used to this, because if you transition into private practice and you're doing these kind of things, that's good medicine for the patient, most importantly, but with good documentation, it's more reimbursement for you as well. So there is a little bit of a return on this. This pays about $37, okay, for doing something you should be doing anyway, but most people aren't documenting, okay? Routine foot care, 0247, now we're talking about actual procedures. Now the reimbursements on this vary a lot, because you're talking about either wound care, if somebody has an ulcer in their foot. I don't do a whole lot of that. Debridement of corns, calluses, trimming and debridement of nails, I do some of that. We personally refer people in our clinic over to wound care. I think that's a better option if you have it available, simply because a lot of the wound care clinics often take pictures. There's better follow-up that can be seen every week or more frequently than that. Anyone with an ulcer, in my opinion, that's diabetic, that has a neuropathy as well, I think should be in routine wound care more for surveillance than anything else, to make sure it's not getting worse. But if you're doing that, all these other procedures are reimbursable also. Footwear, 1 pair of depth shoes. Yeah, go ahead.
What's your experience with my experience with the G codes? Medicare, Medi-Cal doesn't really reimburse for the G codes that much.
And I'm not aware of the Medi-Cal, obviously. That I'm not familiar with the California codes and regulations. In Oklahoma, I have been successful in getting those paid over 90% of the time. With Medicare. I'm not aware of Medicaid on that, but Medicare, absolutely, I can confirm that.
Does that have to be coded with the 25 modifier?
A 25 modifier, yes. That basically it's over and above the basic billing. Okay. So Medicare covers 1 pair of depth shoes and 3 pairs of inserts. They also cover a pair of custom molded shoes and inserts and 2 additional pairs of inserts. So the point is, when they wear out their shoes, it's not like it's their one-time pair of shoes for the rest of their life. Okay, you can get replacements for these things and keep up with the monitoring. To transition over to a different subject, eye care. Diabetic retinopathy is the leading preventable cause of blindness in the U.S. Prevalence of diabetic retinopathy increases with the duration of diabetes. This is a little bit sad for your type 1 diabetics, but 100% of them will eventually, over the natural course of their lifetime, develop some degree of diabetic retinopathy regardless of control. Keeping in mind that most people are diagnosed around age 10 or so, and so if they live a normal lifetime, that's a long time to have a condition that's known to cause this. About 60% of type 2s after 20 years, just to give you an idea on the timeline. So if you have a 75-year-old patient that's been diabetic for as long as you've known them, and they haven't been going to their eye exams, they really need to go at that point, okay? Of all the recommendations, eye screening is the least likely to get done. Now, that's twofold. One of it's just harder to keep track of if you don't have a good flow sheet or registry in the patient's chart. It's one of those things that just tends to slip your mind. It's not quite as clinically relevant to what you're doing right there that day. And sometimes it's also resources that you may just not have a lot of eye doctors in the area that you are, especially if you're more of a rural practice. The thing is, a dilated exam is all that they critically need. So it doesn't necessarily need an ophthalmologist. Sometimes an optometrist will do, okay? The initial screening, I like to get people seen by a full-fledged ophthalmologist, but use the resources that you have available. It doesn't necessarily require that full background retinal specialty to diagnose something like this. Pathogenesis. Now again, I'm not an ophthalmologist, so I typed it out exactly the way it happens. Increased circulating glucose leads to weakness of the capillary walls. Get these microaneurysms and hemorrhages and leakages, and that occurs, so you get these cotton wool spots. So basically you infarct the nerve layers at the back of the retina. That hypoxia, the body senses that, leads to vasoproliferation as it tries to regain the blood supply to those areas. The problem is all those extra blood vessels then lead to fibrosis, further hemorrhage, and then vision loss, okay? So looking at your classic eyeball here, this probably shows up a little bit better on the screen up front. Left eye is normal, and on the right you see, obviously the proliferative retinopathy is all the blood vessels arcing, especially over the top half. You have a little bit of a flame hemorrhage up here around 1 o'clock or so. Some of the cotton wool spots are the lighter colored areas just above midline there. So any of those lighter patches are your cotton wool spots. So this is what you see fairly easily on eye exam. The problem is, you know, how often can you look through a fundoscope and see that? You know, it's really hard. I've often maintained that there should be a support group for family practice doctors that claim they don't know how to use an ophthalmoscope. I personally have a pan-ophthalmoscope, which if you've never seen them, it looks kind of like a, I don't know how to describe that, but a handle and then a long tube that basically has a series of mirrors that gets you further back from the patient's eyes, and you really can see it in a non-dilated eye. If it's non-dilated, it's very, very difficult to see this kind of a picture. You know, you're having to pan through all the different fields. It's very hard, especially if you personally wear corrective lenses. That makes it even harder. So pan-ophthalmoscope's about $200, or the more simple point to this is refer them, okay? That you don't have to do all this if you refer them constantly. If you want to check it, by all means do. That would certainly be appropriate. And it's not that hard to do and identify that vasoproliferation at least. But if you don't have the ability, make the referral. The other point is, I never make any heavy recommendations if there was no point. The point is, this is treatable. With laser surgeries, they can go in and zap all those extra blood vessels and prevent the vision loss. So there's a preventable component to this in addition to making the diagnosis. Any questions over that? We're going to get into really treatment-heavy algorithms after lunch, but any questions over the pre-diabetic state, the pathogenesis of this, or some of these initial screenings? Perfect.